over the years, over the last couple of years, um, realized maybe that inflammation is one of the things that we really need to tackle on a day-to-day level in order to prevent any serious illness, not only COVID. So, Dr. Nazeen Dhawan, the Secretary of IMA DMA and the Associate Medical Director of ENT and the Head of the Safety Committee in Shop Charity Eye Hospital in Daryaganj, is with us today, and she'll be highlighting these features. So without much ado, I would hand over to Dr. Nidhi to carry forward the session.
Thank you so much, Dr. Meenakshi. And some very interesting insights I had when I was doing this. So we'll come to that as we go along. पूरा हफ्ता मेरे दिमाग में कुछ कुछ चलता रहता है कि इस संडे को क्या बात करनी है, बट हम पूरी दिल्ली घुमाते हैं, पूरी दुनिया घुमाते हैं, and we kind of circle back to inflammation every now and then. Just shows how important of a topic it is, one, and secondly, how everything is so nuanced and so connected that picking up one thing which kind of works for you might impact overall health in a geometric manner. So here it goes. हम ना पिछले 2 साल से we have been and it's become a reflex because times are very unsafe. Delta has been very cruel. Omicron has been very viral in its transmissibility. So when we say be safe, we actually mean well. But as doctors, I think we need to rise one level higher and say be healthy. So we have to prepare our patients, our friends, our families towards health, which automatically makes them safer in the emerging times. क्योंकि अब आने वाले time में we are going to see more and more emerging viruses also. Just a very brief view. Israel finally is going down. US is kind of staying at that 364 per million. India is still hugging the baseline around 13. And this is very interesting because सब कुछ खुला हुआ है. People are not wearing masks. People are going to markets. People are crowding. People are doing everything that they used to. We are still not seeing an increasing number of hospitalizations, and we started seeing it here. Okay, let us watch one more week. Let us watch one more week. Let us watch one more week. But we are kind of staying close to the baseline. There might be something happening here, which I'm going to come to during the talk. If we look at the R0, UK R0 has finally fallen less than 0.5, but their hospitalizations are going up. US, it is close to 1, but hospitalizations are going up. India, it's close to 1, but hospitalizations are not happening. Israel, finally, it has come down to less than 1. Why I take Israel as a reference is because it's a very highly vaccinated country and seemingly a very fit country. If you see the share of daily tests that are positive, जहाँ तक सारी countries का आ रहा था, that was here. It's US about 10%, Israel about 4.5%, UK about 4%, and India about 0.6%. That's somewhere here. But if you look at, that's May 15th. If you look at 1 month ago, that's where we still have some semblance of reporting from countries. US is about 13, Israel is about 30, and India is about 2.5%. And then when you come to the end of the last month, Israel is at about 30 and India is at about 3. Now, people are not getting tested. They may be getting COVID. I have myself diagnosed, I think, 2 or 3 in the last week. And they're not getting very sick. The disease is not affecting the general population in terms of its economics, not in terms of its psychology, and not in terms of major health outcomes either. Which means that we are kind of sliding into an endemicity, and we need to stop looking at hard numbers, because hard numbers are not reliable any longer. But why is it important to fortify anybody towards any inflammation? Because अगर हम कोविड की basic pathology देखते हैं तो it is a hyperinflammatory, hypercoagulable, hyperimmune state where the acute viral phase is not really causing the damage. It is the post-viral phase which is a matter of concern, which with Omicron has become less and less. So अगर हम किसी भी acute inflammatory trigger को देखते हैं, any trigger, within seconds to minutes, there is increase in the fluid in the local space. There is infiltration with neutrophils within minutes, and in minutes to hours to days, gradually it's the monocyte macrophage recruitment which comes into play. Now, the monocyte macrophage axis is important because यहाँ पर सारा inflammation का खेल हो रहा है. या तो resolvins, lipoxins, protectins, mericins, all these chemicals will be high enough and good enough for resolution. Yeah, the monocyte macrophage axis will go into inappropriate hyperimmune stimulation and cause prolonged chronic inflammation. This prolonged chronic inflammation has been seen in cancer, in obesity, in diabetes, in hypertension, in all of these things which are marked by lingering inflammation and high CRPs. So, जो initial response है, that is TNF alpha, IL-1 and ROS dominant response. As we move towards resolution, we find TGF beta, IL-10, arginine 1 and platelet derived growth factor predominating. The resolution is kind of triggered by anti-inflammatory macrophages. And it is marked by falling neutrophils. It is marked by IL-4, which is the remodeling molecule. So the cellular dance is pretty clear. It looks like it would be really very fine to just do anti-TNF alpha, anti-IL-1, maybe improve some mitochondrial health, and you should just be healthy. But it's not as simple as that, because inflammation is also the challenge that our body takes to stay healthy. It's like inflammation crosses that point of diminishing returns where it causes more problem, but a little bit challenge is needed for proper functioning to carry on. This paper was very interesting because it is a paper from 17th of May. So it is very current, 2022. It includes the Omicron times. And it talks about some facts as we know them. The facts are that the COVID infection associated immune response is central to pathogenesis of COVID-19. That is a fact. It's not the virus, but it is the immune hyperreactivity which is causing the problem. Innate immune systems sense viral RNA through TLR3, 7, and RIG1 and hyperactivate the innate immune responses. So we see an increase in neutrophils and a downstream decrease in lymphocytes. The dysregulated neutrophil extracellular traps induce immune thrombosis and exacerbate inflammation of lungs in the patients with COVID-19. This is what we've seen in pre-Omicron times. Lymphocytopenia induced by apoptosis and syncytia formation promotes COVID-19 progression again in pre-Omicron times. The vaccines often do not block infection, but provide immunity to decrease severity. Now, all this looks very obvious, but what we are kind of losing sight of is the fact that Omicron is different. Omicron has picked up the immune signature of the common cold rhinovirus, the E22 something. It has picked that genetic sequence from the common cold virus, which may have serendipitously worked for us. But should Omicron cause us similar concern? So COVID, it is assumed, was endemic in bats and jumped species to come to humans. It doesn't cause too much of a problem in bats. And why that is so? There are some immune differences. The bat immune system is balanced between defense and tolerance. Ours is not. Infection is not necessarily followed by pathology in bats. There is enhanced expression of interferons and interferon stimulated genes, and there is increasing tolerance to heat shock proteins in bats. There is a reduced expression for stimulator of interferon gene or STING. Keep this in mind. This is important. There is decreased expression of NLR family pyrin domain 3 or NLRP3 inflammasome. This is important. These are two key differentiators between bats and humans. There is this chance that human monocytes can be infected by SARS-CoV-2 via alternate pathways, about 6% of monocytes, and these may drive chronic inflammation. The other reason why humans are more susceptible is because the mucosal IgM and IgA decay very fast. But that brings us to the important point. Mucosal immunity, we have been saying, is very important. We have been using iodine as betadine gargles or betadine mouthwash, or even the betadine application in the nose. And I mean, this is just a thought. Japan has a lot of rising cases in the last Omicron month or so, but it has very little hospitalization. India, we are seeing whatever the press is saying, कि हमारे को on the ground, we are not seeing very sick patients. Japan has a lot of seaweed in the diet, and seaweed has iodine. In India, we are using salt fortified with iodine. When there is adequate iodine in your diet, it does get secreted in saliva and in mucosal fluids, including the nasal and the GI fluid. Is that the reason? I mean, there could be so many things which are happening at so many molecular levels that we don't know. But if that is, it is such a simple, it is such a simple thing to do. I mean, बहुत ज़्यादा दूर जाने की ज़रूरत ही नहीं है, खाने में सही salt डालना है, so to speak. But that's one thought that I want to leave you with, that, you know, something as simple as adding iodine to your diet in various ways could enhance mucosal immunity at a molecular level rather than at a immune level, which decays pretty fast. So comparing then Japan and India, if you see Japan is red, number of cases going up, I think we are not testing. So this is not very reliable. We could easily be where they are, but if we are not testing, we are not even hospitalizing. Out of the 9,000 beds, 132 are occupied right now in Delhi. The new deaths, look at where India is, look at where Japan is. So both of them are pretty, despite the rising number, this is not rising. If you look at the R0 in Japan, close to 2, R0 in India, close to 1. But again, this is reflected in their numbers. This is reflected in our numbers. No hospitalizations, people generally healthy, public domain largely unaffected. So that's an interesting thought, one thought that I want to leave you with, that diet can have its impact in ways in which we haven't yet explored. There is also this very interesting never cohort, very unusual challenge. This was the human coronavirus challenge, in which about 56 young adults were exposed to coronavirus with consent. And about 44% of these deliberately exposed individuals did not test positive despite exposure. But not only that they did not test positive for COVID, they did not even test positive for inflammatory markers, for CRP, for neutralizing antibodies in the spike-specific IgG. This indicates that there was no adaptive activation. So this is the never cohort, which is very interesting. The never cohort could be working at a mucosal level, and not that their system cannot be overwhelmed by an overwhelming dose of infective viruses, and not that we should challenge ourselves to get infected, but that this cohort does exist. The cell-mediated innate immune response seems to be the key to pathogenesis. It seems to be driven by chemokines and their cognate receptors, interferon family and its genes, including the STING, the TLR7 in the plasmacytoid dendritic cells, the TLR8 in the conventional dendritic cells and the myeloid cells, and I might add TLR3 in RBCs. The TLR pathways have downstream effects on interferons and on antigen presentation, but they also affect late onset uncontrolled inflammation. So it's here that most of the pathology is happening, or was happening, with Omicron. Even this has changed quite a bit. The macrophages seem to be the key cell not only because they are the connection between the the innate and the adaptive immune system, but also because they can drive chronic inflammation. They have high level of ACE2 expression, so they can be the reason for persistence of viral particles. They can be the reason for persistent immune stimulation. They are the trigger for inflammatory cytokines and chemokines, especially the CCL family 7, 8, and 13, the CC motif chemokine ligand, CCL 7, 8, and 13. Now, what do the CCL chemokines do? They induce recruitment and activation of T cells, and activated T cells produce interferon gamma and further activate T cells, so that there is a positive feedback loop of persisting inflammation. The glucose uptake by these inappropriately stimulated macrophages is increased, the ADP ATP balance is decreased, and the ROS is increased. The resolving model starts to work from second day if the patient is otherwise healthy and able to deal with it. So it's the M1, M2 polarization which will either result in persistence of inflammation or resolution of inflammation. The pro-inflammatory M1 family is triggered by pathogen or damage-associated molecular pattern recognition, the DAMPs and the The TLR-mediated activation increases glucose uptake, increases glycolysis, and decreases insulin sensitivity. The activation of cellular metabolism and tricyclic as the citric acid cycle induces hypoxia inducible factor 1, which produces some downstream effects. These downstream effects are on the downregulation of mitochondrial metabolism. So, आप कुछ भी करते जाओ, ultimately 3-4 चीजें निकल के आती हैं. One is mitochondria, the other is nuclear factor kappa beta, and the third is NLRP. अगर हम इन 3 pathways को किसी भी तरीके से, whether we do it by exercise, whether we do it by sleep, whether we do it by diet, whether we do it by a parasympathetic general lifestyle, if we can deal with these 3 things, mitochondrial health, nuclear factor kappa beta, and NLRP, we prepare our patients, our families, our friends for better health. We ensure their safety without asking them to be safe. So the pro-inflammatory M1 macrophages stimulate CD80, CD86, INOS, and are rich in IL-1 beta, IL-6, interferon gamma, and TNF alpha. TNF alpha का सबसे easy antagonist is green tea, but also pentoxifylline if you need clinical help. The M2 macrophages are working on CD206 arginine pathways, and they have cytokine responsivity to IL-10, IL-1, R11, and TGF beta. So these are resolvins and these are inflammants. And they're working at a genetic level. So the monocytes prime the M0 macrophages, which in the presence of interferon gamma go into the inflammatory macrophage state, or in the presence of IL-4 and IL-13 go into the anti-inflammatory macrophage lineage. Now, if you look at the profile of these markers of cellular pathways, you will find that in bacterial infections, TNF alpha, IL-6, and JAK-STAT pathways and nuclear factor kappa beta are all working. In viral, it's largely the nuclear factor kappa beta that is working. In fungal, it is the TNF alpha and the IL-17 that is working. So the Th17 response. In cellular lineages, you find that TNF alpha is produced by macrophages and polymorphonuclear cells. IL-6 is produced by these cells, and these cells are also active for the nuclear factor kappa beta pathway, the JAK-STAT pathway. The T cell lineages are all for IL-17, 23, IL-4 and 13. So they are both inflammants and resolvents. These are for the usually observed inflammation-mediated chronic diseases. So rheumatoid arthritis, psoriasis, Crohn's disease, ulcerative colitis. I don't know which is this AD. I'll come to that in the. So these are all commonly observed. This is axial spondylitis. So these are all very commonly observed diseases in which these markers are activated. And these markers are also activated in COVID. The hyperinflammatory state in COVID is marked by IL-6, TNF alpha, IL-17A, GM-CSF and G-CSF, whereas the resolution is marked by IL-15, interferon alpha beta, interferon gamma, IL-12 and IL-21. So the importance of these inflammatory markers comes in as much as not only do they mark for inflammation.
Yeah.
Dr. Kirana, please mute kar lijiye. Not only do they mark as the markers for inflammation, but also they're providing us easy targets. The important thing is that they mark for inflammation, but using them as target is not affecting viral clearance. And we have enough experience of working with these markers with immune-mediated inflammatory diseases. So targeting IL-23, 4 and 13 axis does not increase risk for viral, fungal or bacterial infections, as we saw in that table. Inhibition of IL-17 marks for fungal candida, but not for viral infections. Targeting TNF alpha and IL-6 increases the risk for bacterial infections and some viruses like hepatitis B reactivation, but not for other viral infections, including COVID. The risk of influenza and complications of influenza are significantly higher in patients with rheumatoid arthritis and Crohn's disease, but these patients also develop a normal immune response to vaccine when co-treated with TNF alpha antagonists. So they need TNF alpha antagonism to develop a normal immune response to the vaccine. IL-15, type 1 interferon and interferon gamma are the primary mediators of viral clearance, and they should not be suppressed. So acute inflammation is marked by this light blue circle, but IL-1, 6, 11, 17, TNF alpha, ataxia and GM-CSF mark the transition to chronic inflammation. TGF beta, IL-4 and IL-10 promote resolution of inflammation. The rest of them are causing persistent inflammation. So if we look at the Th1 pathway along with JAK-STAT and the CCL axis CCR5, CXCR3, then these are the ones which cause increase in IL-2, IL-12, interferon gamma, and TNF-alpha. They seem to drive the antiviral and the bacterial immunity. You look at Th2 dominant response, which is IL-4, IL-25, IL-13, 5, and 10, which is immunity to extracellular parasites. The Th17 response, which drives anti-parasitic as well as chronic inflammation and autoimmunity. IL-21, IL-17A, IL-17F, 22, 24, 26. So these are very specific T cell lineages which are serving very specific functions and are assisted by CC motif ligand receptors of very specific categories. The effector cytokines are very targeted in their functions and they don't show much of cross functionality. But the final common pathway at a cellular level seems to be the nuclear factor kappa beta pathway. The nuclear factor kappa beta pathway, if you remember, brings into play my most favorite molecule, जिसके बारे में हमने बहुत टाइम से बात नहीं की है. So, nuclear factor kappa beta pathway requires the inflammation or the inflammatory trigger molecule to be carried to the nucleus by important alpha beta. अगर वो intracellular हो जाता है, whether it is a viral particle, it's a bacterium, it's a motif, whatever it is, it has to get into the cytosol. From the cytosol, it is picked up by important alpha beta, and it is then delivered to the nucleus where it works on nuclear factor kappa beta. This is blocked by the important alpha beta is blocked by ivermectin. The entry into the cytosol is blocked by HCQS. The entry being blocked into the cytosol also means that the trigger is not available for important alpha beta, which means the nuclear factor kappa beta will not work. So indirectly, HCQS is also working on chronic inflammation, finally pathwayed through nuclear factor kappa beta. All these diseases have at their center inappropriate activation of the nuclear factor kappa beta pathway. So there are several common molecular pathways which have been identified, which are associated with both aging and inflammation, and hence there is a new term that we are talking of, which is called inflammaging. So your biological age may not be as good or as bad as your actual age, your chronological age. You may be a 20-year-old and may have a biological age of an 80-year-old if you're high on inflammation. And the other way around, you may be an 80-year-old with a biological age of 20-year-old if you have kept a healthy lifestyle and kept inflammation under control. So the age-related changes in redox balance, the increase in age-related senescent cells, and the age-related secretory phenotypes show a decline in effective autophagy, which triggers the NLRP inflammasome. When we do fasting, whether it is intermittent daily fasting, as in 12 to 16 hours a day fasting or limited window eating, or it is weekly fasting, as in 1 day or 2 days a week, or it is fasting that was that is a part of our culture, like Navratras, etc. It promotes autophagy. So it actually decreases the NLRP inflammation. Now look at all the simple things which we can do to decrease inflammation. The excess oxidative stress and DNA damage also triggers the inflammation. So increasing anti-inflammatory influences in your life like green tea, quercetin, coenzyme Q10, haldi, turmeric. All these can work at a cellular level to suppress NLRP, nuclear factor kappa beta, and IL-1 beta mediated inflammatory cascades. Autophagy is the main machinery that removes damaged proteins and large aggregates for our body. This is slowed in older age and in age-related diseases. So it allows the damaged material to accumulate and reduce cellular efficiency for the body as a whole. So if there are things that you can do to promote autophagy, you can also, by the same action, reduce inflammation. The SASP, the senescence associated secretory phenotype, produces a positive feedback loop of inflammatory cascade with nuclear factor kappa beta, IL-1 alpha, TGF beta, and IL-6. Now notice that this has TGF beta, which is a resolvent, but it also has nuclear factor kappa beta, IL-1A, and IL-6, which are inflammatory. So it's these which are kind of driving the balance towards inflammation. The NLRP inflammasome is the key component of the innate inflammatory response at a cellular level to pathogenic infections and tissue damage. And this we can deal with by lifestyle changes. This is just sort of an overview of what we have talked till now. But notice that NLRP, nuclear factor kappa beta, and inflammation are very closely linked to mitochondrial aging. And all these are driven by the dance of inflammation and immunity. The overviews then of the inflammatory process is that any stress, whether it is physical or chemical or infectious or even psychological, activates cellular damage, causing damage associated molecular patterns to activate TLR, inducing nuclear factor kappa beta. Steroids work at this level. This induces the COX-2, the adhesion factors, the inflammatory enzymes, and the cytokines. The inflammatory enzymes further cause cellular damage and set up a positive feedback loop. The COX-1, COX-2 axis is suppressed by most NSAIDs. COX-2 is selectively suppressed by rofecoxib and celecoxib, but these have their own problems in chronic use. But you can work on this. You don't have to go down this axis. When we talk about these cellular mediators and we talk about persistent inflammation, what we forget is the preformed mediators. And any trigger, viral, chemical, and sometimes even psychological. I mean, my daughter, she says कि जब वो ठीक से सोती नहीं है तो उसको अगले दिन nasal congestion होता है, and होता है. So something as simple as that, and she will start sneezing. Increases histamine, serotonin, and lysosomal enzymes, which further cause persisting inflammation. So we need to work at, this is like within seconds to hours. This is hours to days. So at the onset of a trigger, there is production of inflammatory mediators by the resident cells, there is infiltration by the leukocytes, and there is a internalization and elimination of circulating pathogen or debris. The resolution stage kicks in when there is removal of the inflammatory stimulus from the local site. There is catabolism of the pro-inflammatory mediators, and they are also removed from circulation. There is a death of the leukocytes, and there is influx of monocytes and macrophages. Now, if these macrophages are of the resolving character, then inflammation within days to weeks resolves. An adaptive immunity with memory is established. Or if it is non-resolving, then TNF alpha stays high, interferons stay high, and IL-6 stays high. The main cells which are affecting this change are the NK cells, which require IL-12 and interferon gamma to become Th1, which produce TNF alpha, which produce inflammatory macrophages. The macrophages in the presence of, or monocytes in the presence of IL-6, which produce Th helper cells, regulator cells. These are positive feedback loops, which produce IL-21, which activate innate immune cells and adaptive immune system. The dendritic cells, which through TGF beta IL-6, 1, 23, activate the Th17 axis, which activates the innate and persisting chronic inflammatory cells. The Th2 activation via IL-4, which works on eosinophils, smooth muscles, B cells for allergy. So the whole axis from allergy to chronic inflammation and autoimmunity requires these cells to be activated by that single trigger. But if you look at nuclear factor kappa beta, there are many natural anti-inflammatories which can inhibit the COX-2 by blocking signaling of nuclear factor kappa beta activation. The natural anti-inflammatories that block this COX-2 mediated nuclear factor kappa beta pathway are haldi, coffee, resveratrol is in red wine, quercetin is in red wine, epigenin, epigallolactin gallate, which is in mangoes, luteolin, salidroside, anthocyanins. So these are mostly plant-derived nutrients that you can include in your diet. This is something that I found very interesting because it talks about approved TNF alpha inhibitors, NSAID responsiveness, glucocorticoid responsiveness, conventional anchor drugs for treating most of the common immune-mediated inflammatory disorders. This includes rheumatoid arthritis, Crohn's disease, ulcerative colitis, spondyloarthritis, axial spondyloarthritis, and psoriatic arthritis. Why this is important is because it gives you the bird's eye view of what agents you can use in what circumstance if you find inflammation in your patients working at certain levels. But अगर एक बर्ड्स आई व्यू लेना है और उसके बहुत मॉलिक्यूलर बेसिस में नहीं जाना है, So there is this pyramid that you can follow. Stay in relative calorie deficit, consume about 1 gram per pound of body weight in protein, do some weight bearing muscle strengthening exercises, sleep well, and include some cardio in your day. If you look at this, I would put probably sleep here, though he's put sleep here. I would say that they're all equally important, that it is not really a pyramid. We all need to have good sleep, good nutrition, probable supplementation, when needed pharmacotherapy, and physical activity in our daily routines. The single episode of exercise improves phagocytosis, decreases TLR activity, causes a variable change in spontaneous cytokine release, and a variable change in chemokine receptors. But if you continue to train, even very minimally, it decreases the monocytes or makes them stable. It decreases TLR4 expression, which drives the nuclear factor kappa beta. It decreases the LPS stimulated cytokine production, which decreases chronic inflammation. It decreases spontaneous cytokine release, but more importantly, it works on the mitochondrial health and improves the body's ability to deal with oxidative stress. So what are the potential agents, anti-inflammatory agents that you could use in pharmacotherapy? We all know these ones which we have been working with during the last 2 years. Corticosteroids, HCQS, azithromycin and doxycycline, NSAIDs, vitamin D, colchicine, ivermectin, anti-TNF agents, anti-IL-6 agents, anti-IL-1 agents, nuclear factor kappa beta pathway, and NLRP inflammasome. It's all here. And what is their mechanism of action? Mostly, the inflammation has these two as their final common pathways. So, now we are not seeing the respiratory distress with COVID, but the steroids suppress IL-2, the monoclonal antibodies suppress interferon gamma, the monoclonal antibodies also work on the IL-6 and the JAK-STAT pathways, the anakinra and canakinumab work on IL-1. So there are several agents, some of which are able to be given orally, many of which need intravenous administration, but these agents work at various levels. So even though HCQS and chloroquine earned a bad name during COVID, for COVID, let's look at their anti-inflammatory effect, which has been used for rheumatoid arthritis for ages now. It decreases antigen presentation. It inhibits T and B cell activation. It balances the T regulator Th17 axis, and it blocks the NOx signaling. The NOx signaling is what increases TNF alpha and IL-8 and other cytokines. So it decreases the levels of circulating pro-inflammatory cytokines at various levels. The importance of HCQS proposedly for COVID was that it increases lysosomal pH. So it prevents the phagocytosis of the viral particles. It also decreases TLR 7 and 9 axis. It suppresses the interferon associated genes. It decreases the release of TNF alpha and IL-6. If you look at ivermectin, colchicine, you see that colchicine is working on the NLRP axis and IL-1 beta. It decreases TNF alpha, IL-6, IL-1 beta, and IL-18. And it also works on antigen presentation, endothelial health, recruitment of neutrophils, and on superoxide anions with IL-1 beta and IL-8. So it works on tissue damage, it works on antigen presentation, and it works on the NLRP pathway. There is a decrease in IL-1, IL-6, TNF alpha with colchicine. There is a decreased release of IL-1 beta and caspase with colchicine. And there is also some probable antiviral action that it affects transportation of the viral particles. The basic mechanism of action is tubulin depolymerization, so that it affects the intracellular transport pathways. So it is also used in promoting endothelial health and suppressing plaque progression and plaque ruptures in atherosclerosis. Steroids, we all know, work on various pathways. They increase IL-10, which is a resolvin. They decrease interferon gamma and TNF alpha, which are inflammins. They increase apoptosis, which improves clearance. They increase TH1, TH2 balance, which increases apoptosis. So steroids are working at various levels. They work on innate immunity, they work on adaptive immunity, they also have anti-tumor immunity. So steroids are broad spectrum immune modulators. And by that same token, also immune suppressants have to be used with care and have to be used with caution. जो कहते हैं ना कि under medical supervision, the disclaimer. Vitamin D. Vitamin D क्या करती है? Vitamin D has its actions on so many levels. TH1 may it decreases IL-2, interferon gamma, TNF alpha. So it decreases the differentiation of B cells, causing decreased proliferation and production of autoantibodies. It increases apoptosis, so clears debris quickly. It makes the immune system more efficient. It improves IL-4, decreases interferon gamma, so improves efficiency of natural killer cells through the TH17 axis. T regulator cells, it decreases IL-6, IL-1, it improves phagocytosis, it decreases TLR response. So the M0, the naive macrophages and monocytes are suppressed and not brought into play to inflammatory monocytes. So suppresses chronic inflammation. The TH2 axis, it decreases the dendritic cell expression of MHC2, it decreases expression of CD40, 80, 86, increases IL-10, which is a resolvin, increases CD14, which is a resolvin, it improves IL-4. So vitamin D decreases maturation of dendritic cells, it decreases cellular proliferation, of B cells in autoimmunity. It decreases cellular proliferation of T cells and cell-mediated tissue damage. And it decreases IL-8 and IL-1 beta so that it improves macrophage of the anti-inflammatory character. So it affects bones, skeletal muscles, cell proliferation, differentiation, autoimmunity, immune function and defense, glucose metabolism, vasculature, blood pressure. Abhi recently aapne suna hoga, beware of vitamin D capsules. So beware of anything, but adequate levels of vitamin D, if you are relatively active, can be taken from sunlight as well as from some dietary sources and have far-reaching autocrine and endocrine effects. This is just a overview of what vitamin D does. It works on both adaptive and innate immunities and works on monocytes, macrophages, cytotoxic T cells, B cells, and the T cells of Th1 to 17 and regulator categories to ultimately decrease inflammation and autoimmunity and to increase body's ability to fight with allergens and bacteria and inflammation. So in short, there is a need to follow an anti-inflammatory lifestyle, whether assisted or not by chemistry, which may be pharmacotherapy, which may be lifestyle, which may be supplements, which may be anything. The diet rich in nuts, berries, salmon or fish oils, quercetin, coenzyme Q10, resveratrol and astaxanthin is an easy way to start that journey. Be the doctor that your patients can trust, prepare them for health to be healthy, fortify their safety to be safe. And that's all I think I have to say today.
You've said quite a bit, Dr. Nidhi. Thank you so much for being at the root of all evils. So this is exactly what we have been talking about for the past 2 years, and it's been quite a realization that everything just boils down to this one factor, whether it be obesity, whether it is all the lifestyle diseases, even cancer. The root of all these things would sort of boil down to inflammation. And thank you so much for doing such an elaborate talk on this very topic. So now the floor is open for questions.
Dr. Poonam has made a comment. And I'm very sorry to hear that, Dr. Poonam, that you lost your uncle to COVID, severe pneumonia. There might have been some underlying, because as I said, the syncytia formation is not happening with the present variant. Hence, lung infections are rare. I don't know which variant.
But not to distract, this could, there are some cases of the Delta, sort of going around. It's very, very rare. It's almost encapsulated all of the, the population, but the people who've been absolutely not exposed. So she said he's not left home for the past 1 year. So if he's not been exposed at all to the Delta, then maybe, he could have gotten that, because Omicron ke saath mein to pneumonia hum dekh hi nahi rahe. But Dr. Nidhi, as I told you, I have seen personally, since the Omicron has come out, I have seen a few cases of pneumonia. Not very many, a very, very small percentage, but I would like a very tiny percentage. Maybe I've seen around 4 or 5 cases of pneumonia, but they are there. So, if he was elderly, or if he didn't have a very strong immune system, then but then regardless, Delta did not spare the people who were healthy either. So
I am not able to unmute Dr.
I'm just going to change the setting because there were a lot of
I got it.
participants.
Manisha.
Ji, ma'am.
My question is first that Meftal is missing from your list.
नहीं, NSAIDs में मैंने उसको एक common कर लिया है, but yes, I haven't gone into Meftal specifically. I haven't even talked of. I think Nimesulide is also very good in these circumstances. So it's not an oversight. It's a blanket with NSAIDs.
Okay. But then I found it better than most NSAIDs, especially like Brufen and some of the others. And almost at the level of probably HCQ and colchicine, because they had started, denigrating long list HCQ, ivermectin, doxy, azithromycin included. So I started using Meftal more and more, and I found beautiful response along with vitamin D and some of the anti-allergics, Montec included.
So I would say that as I said, histamine is prominent in the initial stages, and histamine के लिए हम लोग H1 तो कर लेते हैं, like you said, Montec LC or whatever, but we should also include famotidine or ranitidine, because H2 is also very important.
Right. So HCQ and ivermectin, colchicine have returned in the eyes of the world for treatment of COVID, or not yet? So WHO has gone blanket, antagonism to all these agents. So beautifully anti-inflammatory effect there should, and anti-infective.
So the chemistry says that they should not be avoided, and the levels at which ivermectin, HCQS, and I've shown it to you today, they work are logically, cellularly speaking, viable pathways of action. WHO has not said that you can't use it. WHO very smartly has said that you can use it in research settings.
It's confusing.
Madam, what is the advice to be given to the patient?
Government of India followed up with the same.
Yes. And हमारा मैंने आपको कहा ना कि हमारा जो performance है in the pandemic, I think there are a lot of things which are in our favor. One is, of course, that we are a relatively young population, so that those age-related changes in cellular chemistry are not against us. 60% of the population is less than 20 years of age, which is really huge. The other thing that is, मतलब ये करते करते जो मुझे लगा कि अगर fortification with iodine incidentally has helped us, because I heard Dr. Campbell say that seaweed, and you should include seaweed in the diet, and I thought, but hamara iodized salt, and then I went to check whether iodine is really secreted in the saliva and in the secretions of the GI tract, and it is. So it ranges from 0 to 200 micrograms, depending on the dietary load of iodine. So that's pretty simple way to improve immunity if you look at that. So that might be one reason why India has performed better. The other is that we had an open mind and we were willing to and able to use drugs off-label in the initial stages. When we talk as doctors, ना हमारे को ये होना चाहिए कि हम logically उसके molecular action को देख के अपने patient को treat कर रहे हैं. Guidelines can be guidelines, they cannot be mandates. because our first responsibility is to the patient who comes to us. And if we see certain chemistry, we know what is working in that. Now, Trental has not been used in COVID for any, and is not, there are no papers on it. But TNF alpha के लिए एक बहुत simple anti-TNF alpha agent है, which doesn't require IV administration. And that's the only thing that worked with my father's skin condition post-COVID.
Right.
So I think that we have a huge advantage of being a community where हमारे ऊपर ना डंडा नहीं है. शायद उसकी कमियां भी हैं, खराबियां भी हैं, लेकिन generally speaking 90 to 95% of us are पढ़े लिखे doctor who want to use our head and are able to.
Even US, some of my relatives, even my own son, refused to listen my advice because ये सारा कुछ उसके वहाँ के कोविड स्पेशलिस्ट ने नहीं बोला था, सिर्फ पैरासिटामोल बोला. I mean,
वो उनका यूएस का जो टिपिकल लाइन है ना, टेक पैरासिटामोल till you turn blue and when you turn blue come to the ICU.
Yeah.
Whereas our deal has been don't let moderate
become severe, mild.
Severe, don't let mild become moderate. And it shows in the results.
Yes, wonderful presentation. I think you are going to cellular level and molecular level specialist, both in the pathology and the treatment. But still, I have one request. If you can have 1 or 2 slides in the end, because see, at mentors, which is very difficult to understand many slides. So at last 1-2 slides as a take-home message or summary, because what exactly you want to say, so that can be summarized in 1-2 slides. That will be much better, especially when you're speaking at the molecule level or
Point taken, sir. Point taken.
One more point from me, Dr. Nidhi, Dr. Meenakshi. You all have limited WhatsApp groups of doctors, and do include Dr. K.K. Agarwal's class karke, and so that we can spread the word around at least 2 days, 1 or 2 days prior. Like you had given a small thing in Dr. K.K.'s group, but में उनका नाम नहीं था, plus topic था, so that we can spread around.
ठीक है,
right. So a creative of sorts. We'll try to work on this. I think a lot of suggestions today, not too many questions. I think this is a topic that we have been working on. So, between the waves, this is exactly what Sir used to talk about. When the wave was all, at the peak, then us samay, itna time nahi hota tha to get into the molecular level because we were just dealing with the symptoms and the, the treatment and everything. But between the 2 waves, he would always try to, sort of get into the, the root of inflammation, and Dr. Nidhi has done that very beautifully today, and I must thank her for the same. And a big thank you to all of you as well for joining in and keeping the show alive. We'll be back again very soon. Until then, goodbye.
Thank you.
Just a minute.
Thank you, madam.
Yeah, sir.
Encourages us